The three classifications of heart failure. Excuse me. The cause of heart failure determines if it is acute or chronic. Depending on the cause, one ventricle may be primarily affected. In most cases, it starts with the left ventricle and progresses to failure of both ventricles. Left-sided heart failure is primarily pulmonary congestion. The etiology can be hypertension, coronary artery disease, or valvular disease. There are two types of left-sided failure. There's systolic heart failure. This is when the left ventricle fails to contract adequately to eject sufficient blood, reducing the ejection fraction to less than 40%. These patients can be at a risk for sudden cardiac death, and a lot of times will have internal defibrillators placed if they are unable to get their ejection fraction greater than 40% with primary with medication treatment and non-invasive treatments. Diastolic heart failure is left-sided heart failure when the left ventricle cannot relax enough during diastole. And because it can't relax during the diastolic function, it's because it is due to the decreased vascular compliance. The heart is stiff. Think about like a balloon that a kid's been spitting into. You can blow it up, but you're not going to get all the air back out of it. It's never going to look like a fresh balloon again. So with diastolic heart failure, you have that balloon that's kind of big and puffy, where it just can't, it's stiff, it's hard, it's not as pliable as it once was. And these people's ejection fraction can be above 40%. But that is when it is the diastolic heart failure. Systolic heart failure is more common. Alrighty then. Moving on to the next, we have right-sided failure. Now, right-sided heart failure is when the right ventricle cannot completely empty. A lot of times the cause can be left ventricular failure leading to that right ventricular failure, or it can be a right ventricular MI, and it can be pulmonary hypertension. It can also be caused by high output because of increased metabolic needs, such as in cases of sepsis, anemia, and hyperthyroid. So that is right-sided heart failure. And it's when the right ventricle can't empty completely. It can be from most of the time when you see right-sided heart failure, it is a progression of left-sided heart failure. With right ventricular, you can also have, the patient can have had a right ventricular MI that can cause the heart failure. Also, pulmonary hypertension. Right-sided heart failure can also be because of high output with increased metabolic needs, such as in cases of sepsis, anemia, and hyperthyroid. Okay, so this picture is straight out of your textbooks. It is on page 693. It's figure 35-1. And what it looks at is the compensatory mechanisms of heart failure and how the myocardial dysfunction activates the renin-angiotensin-aldosterone cycle, which then in turn the sympathetic nervous system is able to come into play. So as you can see with myocardial dysfunction, whether it's an MI or ischemic heart or hypertension, you have decreased cardiac output, decreased systemic blood supply. That activates the baroreceptors in the left ventricle, aortic arch, and coronary sinuses. The vasomotor regulatory centers in the medulla then are stimulated, which starts the sympathetic nervous system, which is that fight or flight. So you have the increase in the catecholamines, your epinephrine, your norepinephrine, which causes vasoconstriction. Now remember, because cardiac output is the product of the heart rate and stroke volume, when you first have that fight or flight going on and you have that increased heart rate, you have an immediate increase in your cardiac output. But because the heart rate is so fast, when it becomes tachycardic, and it's going as fast as it can, it's not emptying as well. So you end up, its ability to compensate for the decreased cardiac output, because the heart rate is limited, because when it is going so fast, it isn't giving it proper time to both empty and to fill. If it becomes too rapid, the diastolic filling time is limited. So that's where I'm talking about when the heart rate becomes so rapid, the diastolic filling time becomes limited. The cardiac output then may start to decline. And as the heart rate increases, you have significant increase in oxygen demand of the myocardium. If the heart is poorly perfused, it may actually worsen the heart failure. So when they become tachycardic, the ventricles don't have time, because they're trying to go so fast, they're squishing, but the blood doesn't have time to fill. So that's the reason, as they become more tachycardic, you may actually end up with a decrease in your cardiac output, because the stroke volume, because as the heart rate increases, you do not have the fill time needed in order for the blood to be contracted out to the rest of the body. I hope that makes sense without confusing you. So without going into a whole lot more of the patho, so now that we have this low output state, it causes decreased kidney perfusion. So with the decreased kidney perfusion, the renin-angiotensin-aldosterone system is activated. So with all of that going on, you then can have a decrease in your cardiac output, retaining both sodium and water. So when you have times of decreased cardiac output, you have decreased perfusion to the kidneys, which retains the sodium and water, which worsens the heart failure. Also, in times of low cardiac output, you can have a decrease in your cerebral perfusion as well. I hope that makes sense without going into too much of the pathophysiology, because we just don't have that much more time for a review. Left-sided heart failure. I've always remembered it as left lungs. If you're talking about left-sided heart failure, your lungs are going to be involved first. Medical history. Do they have hypertension, angina, history of MI, rheumatic heart disease, valvular disorders, endocarditis, pericarditis? Have they had activity intolerance, weakness, or fatigue? When you ask them, do you get short of breath with activity, you need to know with what activity. Because they may go, oh no, I don't really get short of breath, but I also don't get out of my chair. Or yes, I've noticed that I'm starting to get short of breath when I just walk to the bathroom. I used to only get short of breath when I walked all the way to the mailbox. Now I get short of breath just going to the bathroom. Or yes, brushing my teeth causes me to become short of breath. They can have orthopedic, where it's shortness of breath at rest. And where that comes into play is where you have patients who perhaps they used to just have dyspnea when they were, with physical activity, but now even at rest, they're short of breath. And that's very important to take into account if they're all of a sudden having it more at times of rest. Paroxysmal nocturnal dyspnea is a sudden awakening with air hunger, causing increased anxiety. They'll have a weakness and heaviness of their extremities or in their chest. And this can be worsening signs of left-sided heart failure as well. A lot of times, people will not have the shortness of breath at rest when they're sitting up. They will have it nocturnally when they're laying down. And it usually happens about 2 to 3 hours into sleep. They all of a sudden wake up in a panic because of that air hunger. Now, the cough with pulmonary congestion is very important to look at. With cough in early left-sided heart failure, it's really just a dry, irritating cough, especially at night. They may say, I don't cough all day, and then I lay down, and all of a sudden I've started coughing. In a late sign of left-sided heart failure is when they cough, they have this pink frothy sputum. Pink frothy sputum is a telltale sign of pulmonary edema, and pulmonary edema is life-threatening and needs to be taken care of emergently. So that would be in the later signs of congestive heart failure, you will have pink frothy sputum. And this is pulmonary edema. It's the telltale sign for it, and it is life-threatening. These patients are panicked. They're sitting straight up in the bed. They can't catch their breath. They are literally drowning in their own fluids. So this is a acute condition that is life-threatening. It will be covered. Pulmonary edema will be covered more in 495, but because we're talking about chronic left-sided failure, we need to know when that failure worsens to the point of pulmonary edema, that pink frothy sputum is the telltale sign for it. When looking at left-sided heart failure, remembering left is lungs, neurologically, you may find the patient complains of dizziness or confusion, and sometimes they'll have feelings of depression. As far as the renal system goes, remember, because of that decreased blood flow, they may have limited urine output, or they may have nocturia, where at night they're getting up 2 and 3 times a night to void, where they don't go during the day. And if you think about it, they have more of a chance at night for because the rest of their body is at rest. The blood flow to the kidneys improves, and they will make more urine, and so they'll have to get up to release that urine from their bladders. And that's also a telltale sign of when someone is starting to, I don't go to the bathroom all day, and then at night I'm starting to go a whole lot. Sometimes it's a sign of their left-sided heart failure. Cardiovascular system. We've already talked about that they can become tachycardic. They can develop an S3 gallop. In Jean Marie's world, you always take an apical pulse for a full minute, but especially when you're trying to listen for a deafening heart sound, or when the patient is tachycardic, so you can hear if there's any dysrhythmias that you can hear. Pulmonary wise, for lung sounds, these lungs are going to be very congested. You're going to hear lots of crackles. You're going to they may talk about how their sputum has become very wet. They'll have an increase in their respiratory rate. So here again is a little fella here with that left-sided failure. It talks about how he has that panic, air hunger at night. He's restless. He's confused. He has the tachycardia. He has the exertional dyspnea. This here is really just a good place. It's saying the exact same thing I've already said, just showing it in picture form. So it's showing how that his extremities are heavy. It's just giving you a little bit more of a visual on our patient with that left-sided failure. And I'm going to stop talking before YouTube fusses at me.